Good morning, everyone. Welcome to our session. I'm Marina Basina. I'm from adult endocrinologist from Stanford University. And I have a great pleasure of moderating the session today and looking forward to hear all the great talks. Our first talk is titled Streamlining Automated Insulin Delivery Sick Day Protocols to Reduce Communication Load. And it will be presenting by Arati Nagarkar from Stanford University, from my home institution. Thank you, Arati.
Hello, everyone. My name is Arati. I'm the QI coordinator of Stanford Adult Endocrinology. Let me introduce my clinic. We have about, is this working? How do I? Yeah. So we have about 7 MDs that deal with primarily diabetes patients. We have 3 nurse practitioners, 6 RNs, 2 registered dietitians, and 1 psychologist on board. And on the inpatient side, we have 2 APPs that are also CDs. I'm going to talk about sick day management protocols for patients on automated insulin delivery systems. The current problem that we see in our clinic, that is an increasing number of patients are on automated insulin delivery systems. And these patients, when they fall sick, their pump settings need to be changed. There is no set protocol right now that exists that defines what the settings are. And messages are sent to the providers and they stay, they wait for responses. And there is some timeline between when they are resolved, these queries are resolved. And this accounts for all the delays in patient care. So our aim was to improve the efficiency between patient messages and provider responses. That involved shortening the turnaround time between the patient and the provider, also reducing the messaging overhead between RNs and providers as well for sick day management. The current process map looks like this. The patient sends a message or calls in. The RN picks up the message, calls back the patient, gets all the information, talks to the provider. There's a lot of back and forth as to what the optimal settings might be. And then the RN responds back to the patient with the settings. We came up with a fishbone diagram which highlights some of the issues that we see currently in the system that contribute to a delay in patient care. One of the most important things is patients, as they go on automated insulin delivery systems, these systems are becoming more sophisticated. They've evolved into very complex machines, and patients are not very comfortable trying out new settings. They're not, very tech savvy, and they don't want to experiment with things. The product itself, they miss out some of the updates that are there for the pumps, so they need to be regularly prompted. The place has only a finite number of triage nurses that can respond to patient messages. The process of getting optimal settings is very time consuming because it contains a lot of steps. It's not very standardized. So major delay is in the process itself, as well as there's a lot of MD and RN fatigue in the sense that they have to deal with their regular clinics, and then they address the patient messages that are waiting at the end of the day. So we, at our clinic, we created a survey, and internally we sent it to all the MDs that deal with diabetes patients via SurveyMonkey platform. And externally, we send the same survey through T1 D-Exchange. The survey contained a case study of a 35-year-old female that has a history of type 1 diabetes. And she's basically, she has days of congestion, sore throat. She has 2 days of fever. She has tested positive for COVID. And she has blood sugars in the 200 to 250 range. And we match it up with all the commercially available pump systems that are preferred by diabetes providers. So the first being Tandem. And keep in mind that every pump, because of the way it operates, we tweak the options that we gave the providers. So for Tandem, we had A, switch to manual mode, increase basal rates by 20%. B was switch to subcutaneous injections for the next 2 to 3 days. C was continue auto mode, take 10 units of Lantus in addition to the pump. D was continue auto mode and change carb ratio and ISF factor to a tighter value. And E was creates a sick day profile with increasing basal rates and the carb ratio and correction factor again to a tighter value. And F was none of the above. And you can see that about 16 providers chose creating a sick day profile. And 10 of them said continue auto mode and change the carb ratio and ISF factor to a tighter value. And about 2 of them opted for none of the above. When they choose none of the above, they want to do their own custom settings for things. The next up was Omnipod. And for Omnipod, the preferences were varied. They were spread out. About 7 of them chose manual mode and increasing basal rates. 2 of them chose continue auto mode, take 10 units of Lantus in addition to the pump. And D, most of them, like 12 MDs chose continue auto mode, change carb ratio and ISF factor to a tighter value. And about 4 chose none of the above because they wanted to do their own custom settings. Medtronic was very similar, and they many of them chose continue auto mode, change carb ratio and ISF factor to a tighter ratio. And then some of them, like 3 of them, chose switch to manual mode and increase basal rates by 20%. And quite a few, like 5 of them, chose none of the above. Last was iLet. And as you can see, there was not a real consensus on what we should be doing because iLet is a self-learning pump. So even our options that we gave the MDs were a little, subject to change because we're still discovering what we can do with iLet. So A was switch to injections for the next 2 to 3 days. B was enter meals larger than usual. And C was none of the above. And you can see that there's not really a preference, although 10 of them chose none of the above. 6 of them chose enter larger meals. And about 9 of them chose switch to subcutaneous injections for 2 to 3 days. So from the study, from the survey that we did, we noticed some limitations to this. Tracking patient messaging, how do you really gauge whether you've optimized, the back and forth messages? It's a retrospective review. We also noticed that if we want to look at the speed at which we are responding, we have to look at the timestamps and really review how fast we are responding to messages, patient messages. And since a large portion of providers chose none of the above and wanted to do their custom settings, we might have a difficulty in buy-in to our standardized protocol. But in our clinic, we want to try this out. We want to have like a sample protocol. We want to test it out with 2 RNs and see whether it's a success before spreading it out to the rest of the MDs in our clinic and having it like a standardized way of procedure for us. As a future option, we really want to publish a set of advisories for each pump by consulting the experts in the field, having a discussion about the in-depth settings that can go with sick day management, and having it as a standard for the rest of the MDs across the United States. This is our draft pump protocol for different pumps. As a side, Twist has been just released. As it becomes more commercially available, we will be adding it to this protocol view. So you can see that Medtronic and Omnipod have similar advisories. Continue auto mode with a carb ratio and a correction factor that are both 30 to 50% tighter. Tandem has create a sick day profile with increased basal rates, a tighter carb ratio, a tighter correction factor, and continue control IQ mode. And iLet is continue auto mode, consider NPH or Lantus for significantly increased insulin requirements in addition to the insulin pump. Having said this, we also want a snapshot of the patient's last sick day settings. This is because we feel like if we have the previous sickness, if we record the previous sickness of the patient and record their settings, between the advisory and these settings, we can come to a faster conclusion of their pump settings. And that's the plan, actually. Thank you for listening.
Thank you. And anybody who has any questions?
Thank you. Hi, I'm Melissa from Children's National, one of diabetes educators. And my question is, now that on Tandem, you can set a temporary basal rate on top of automated mode, would you consider adding that instead?
Yes,
Okay.
we would. But again, we want it to be a wider discussion with all the providers that actually play a major role in diabetes treatment.
Okay.
Thank you. I think it's a great question. On Tandem, yes, you can do temporary basal rate, but it's only for basal. And frequently patients, especially getting on steroids for asthma, it would be more prandial that might be affected. So on Tandem specifically, I don't know, maybe that's my personal opinion. So usually creating sick days management is more, but yeah, that's a great option too.
Hi, my name is Brooke. I'm a diabetes educator from Helen DeVos Children's Hospital. I was just curious, as you were working through these protocols, if you were going to add in anything regarding ketone management and standardizing that among your clinic. I know we have kind of our protocol, and that's probably different than everybody else in this room, but you didn't mention that, so I was just curious.
That's a very good question, and we would like to in the future. But currently, we want to get these set of protocols standardized before we move to ketone management.
Hi, my name is Haley. I'm one of the faculty at SUNY Children's Hospital. I feel like these protocols primarily focus on hyperglycemia and sick day, whereas hypoglycemia and like gastroenteritis is a big concern and often what gets our kids admitted. So just wondering like if you plan to have a separate protocol based on the chief complaint or kind of how you're going to deal with that type of illness.
We plan to have a separate protocol, but that we haven't really discussed in terms of what we can do in terms of standardization of treatment. We do have a standardized set of instruction that the MD gives to them if they go into hypoglycemic events. But since we did deal with adult patients for diabetes, we haven't really gone into pediatric care as such for these protocols, but we will be expanding.
That's definitely a great point to include for sure. Any other?
Your presentation was great. My name's Laura Emmons. I work at Penn Medicine. Just had a question about your smart phrases a little bit more. So in terms of like the previous sick day profile, would you add that to like a templated smart phrase?
Yes.
Like, is that part of a telephone encounter? Are you recording that in the patient chart for further? Because I know like some of these, like it just gets so redundant with the
It can be pulled into the, because it's on the flow sheet, it can be pulled into the telephone encounter by the RN.
Okay, even if it was like a year ago or something, do you update it or?
Not for a year. We need to talk to IT regarding pulling it for encounters a year ago.
Yeah.
But for the current, from present on to future, we will be adding it.
As long as you're just titling it in the note what it was, so that they can kind of like sift back to it, possibly.
So we are working with IT on the visibility of these flow sheets because currently they only are there for the present encounter, and you can view them. But I doubt if we can pull them into past encounters. We can pull them into current, you can create another documentation encounter or a telephone encounter and pull those old notes in, but not go back, I think.
Sure.
Perfect.
Thank you.
Great. Thank you so much to all of you for all the great comments. And I think because of the sake of time, we're gonna move to our next presentation. And we are welcoming Vivian Lee, who is a medical student from the University of California, Davis, to present on a topic, having backup implementing safety nets for insulin pump failures.
Good morning, everyone. My name is Vivian. I'm a medical student from the UC Davis School of Medicine, and Myself and a couple of wonderful members from my team are here today to discuss the initial results of a study we did to try to improve backup plan documentation for adults with type 1 diabetes. So a little bit of background, 60% of adults with type 1 diabetes are on insulin pump therapy, and the pump site failure accounts for about 57% of diabetic ketoacidosis events among pump users. And professional societies like the ADA and the ADCES have recommended that patients have a pump backup plan to mitigate this risk. So what was the problem we kind of saw, like with the patients we chart reviewed? Complete backup plan documentation, which we defined as having an active basal insulin prescription, but also instructions on the dosing of the insulin and their pump settings available in an after visit summary. They were often absent or they were placed inconsistently in Epic. So our aim was between November 2024 and August of 2025, a period of 9 months, we wanted to increase complete backup plan documentation by about 15% and also standardize it using a feature in Epic called insulin instructions. So firstly, we did a retrospective chart review where we kind of looked at the frequency of the patients having the necessary components of a backup plan just at baseline. And what we saw was that patients more often than not did not have an active basal insulin prescription despite actively being on pump therapy, and that a majority of patients did not have all components of the successful backup plan, whether they're missing the active basal insulin prescription or missing some kind of documentation of a backup plan anywhere in the chart. As a matter of fact, a majority of the patients did not have a backup plan at all in the EMR. And for the patients who did actually have a backup plan documented, the location of this backup plan kind of varied very widely across providers. So we first we also then surveyed our adult endocrinology providers and asked a few questions. And one of the questions we asked was, how do you document a backup plan or communicate a backup plan to patients that you talk to? And again, the methods varied widely. Multiple methods were often used together, which, a combination of I just kind of talk to them about it like during the visit. I use free text or I kind of document it in the actual prescription text of the basal insulin prescription. And we saw that even though a lot of our providers heavily relied on using Epic to document pump settings or CGM settings and to prescribe the active basal insulin, knowledge of Epic's insulin instructions was pretty much non-existent. Many providers didn't really know how to know about it or have not heard about it. So what did we do about this? So our intervention then was first at a division meeting, we provided re-education on what a complete backup plan was for pump users, which again included having an active basal insulin prescription, but also having instructions available to patients in an ABS. And this intervention included an instruction video that was made by our team, kind of documenting and kind of going over like what insulin instructions was, how to find it, and how to use it, which we won't show the whole video right now, but there's a QR code available if you were interested in finding where it was. But the upshot of this is that insulin instructions is kind of feature that you can find on the snapshot view or also the medication orders tab to Epic. It's a template that you can use to fill in pump settings, backup basal insulin instructions, and with a smart phrase insulin instructions it will pull this template immediately into both the note and also the patient's ABS. And this can be refreshed every single time you have a visit or in between visits so that patients always have an up-to-date backup plan and also basal insulin instructions when pump failure happens. In addition to the video that we shared, we also placed step-by-step guides on how to access and use Epic's insulin instructions provider workspaces, just for reference if they weren't able to find it the first time or if they were having trouble locating it, when they had clinic days. So over the 9 months after the intervention, we kind of assessed change in the complete backup plan documentation and the usage of Epic's insulin instructions after we provided this education. And we saw that our Epic insulin instruction usage increased from 0 to 27.9%. So having some variable engagement there. But overall, after re-educating on what a complete backup plan was and what that should consist of, the complete documentation of both an active basal insulin prescription and also instructions for the patients in an ABS and increased significantly. And this wasn't included in the slides here, but we also had data that showed that active basal insulin prescription also increased by about 20%. So we went from a majority of patients having no active basal insulin prescription to a majority having an updated insulin prescription that they can use. So what are our next steps? Where do we go from here? We would like to resurvey our providers again, just to continue to engage with them on if they're using Epic's insulin instructions, how they're feeling about it, and continuously kind of checking in on how they're communicating a backup plan to patients on pump therapy. We want to have continued education on accessing and implementing Epic's insulin instructions and continue showing them how to use it. Again, it's usually found in the medication and orders tab, but there is now an easy way to access it with the snapshot view on Epic. And hand in hand with that, we would like to do an annual technology update clinic where we gather and we show providers like how we can utilize this tool in the care of our patients with type 1 diabetes. So our takeaways are that from this intervention, we significantly improved our backup plan documentation overall and increased Epic's insulin instruction utilization, though again limited by variable provider engagement, but hoping that we can improve that, as time goes on. All insulin pump patients should have a backup plan documented in a standardized location because inconsistency of this documentation jeopardizes safety. If we're not able to find this information or the most current pump settings or a backup plan available, that can really be disastrous for patients' blood glucose control. And to tackle the issues of both the lack of complete backup plan documentation and also the standardization and the ease and availability of where you can find it, we recommend using Epic's insulin instructions because of its ease of use and its success with our pediatric colleagues who have been using Epic's insulin instructions for a while prior to us starting this. So again, we'll have the QR code up to the instruction video if anyone is interested, but thank you for your time.
Thank you. That was really great talk, and I'm ready. Thank you so much. Great to see you as a medical student here presenting. I'm Lisa Wolf from Johns Hopkins. One of the questions that has come up for us, in addition to providing the backup basal insulin as well as the instructions to, switch over to basal bolus when you have a pump issue, is in children, the doses diabetes is very dynamic and the doses are always changing. So we've been reluctant to put exact doses into the ABS because if they pull up the papers from a year ago, they could be very different. So how have you guys addressed that in this program to make sure that we're making sure we're giving them the most up-to-date doses?
My team members would love to answer that.
Hi, I'm Carrie. I'm from UC Davis Pediatrics. I'm not part of this study, but we have implemented all this stuff for a while. And so we're happy that our adult colleagues started to kind of use the system the way we do. I would say that in peds, we obviously see the same thing where we are. And I'm very lucky that my colleagues and I are very dependent on this. And so as a result, we all have incorporated it into our workflow so that if anyone calls, if you make any changes, we all update it. So in each encounter, you can access it and change it. And I actually work on the inpatient side for the majority of the time. And it's really helpful because it's almost always updated. And then on the inpatient side, if I make any changes, I update it. So I think it just needs to be part of the workflow and understanding that this is the way that you're communicating to everyone that I spoke to this person and we made these changes. so that the next person going forward has a way to access things without having to like read through everyone's notes and things like that.
That's for like the current.
Yeah.
What about backup for basal bolus, if you're switching off a pump and you give them a specific number?
Yes,
It might be different 6 months from now when they come to us.
that's true. We make a point of doing it at least every year in our annual visit. And then it is kind of tricky because I think that can fall through the cracks, but usually the providers will try to update that as well. But yes, it's less reliable.
Inpatient, but adult as well. And we, from our inpatient side, we do, so they may go home on different pump settings, but the backup plan is right there in the insulin instructions. You'll see if you watch the video, so that we actually actively change the basal, and mealtime doesn't change as much sometimes, but we're actively changing it every time. We did not have a great engagement, but it's actually improved. We have this endocrine snapshot now that has the insulin instructions really accessible, and then we have a smart form underneath that with diabetes overview that's been helpful to kind of get provider engagement. Pizza's been great, but.
Thank you. This is great. I'm amazed that you're all doing this. Just a quick follow-up from me personally. Yes. How do you have, so I use the insulin instructions all the time during the visits, but it takes time to manually enter all this information. So I'm very impressed that you're actually doing and have time doing this.
I think once you do it once, then after that, the first time.
This is mostly just a comment actually to your question of what we do in our pediatric space. So we definitely make a point at each follow-up visit to update the EVS with settings and stuff like that. And as an educator, part of what I do with my patients is, especially for like Omnipod, your total daily and what you get in automated basal might be different than your settings. And so I think as educators, that is something that we focus on, and we might say, hey, this is what your Lantus dose might be. Another initiatives that we've done is actually teaching families how to access their own settings for pump failure. If their pump dies, this is how you access your settings to program a new one. And that's been a really big push to kind of encourage autonomy. And so with that, we might say, hey, this is your Lantus, double check and see if this is kind of close. And if it's not, then call us. And I feel like that's been really well received, to put ownership on the family to like know where their stuff is, so they're not just kind of at a loss. So that's what we do.
This would be our last question.
And less of a question and more of a comment also to Lisa's comment about how do you keep up with the doses. So begging and borrowing is stealing shamelessly from Mercy Children's. We created a ketone sick day calculator. So our diabetes sick day is a website that you actually go to. And again, we teach them how to go to find their total daily doses and total daily basal, and they can put that in the calculator, and then it'll calculate their ketone corrections as well. And we also have medication reconciliation. Probably every institution should have medication reconciliation. So part of that medication reconciliation is, do you have backup basal? And so making sure that it's on the medication list is another opportunity to make sure that those are updated frequently.
Great, thank you. And we can leave more questions for the end if we have more time left. And the speakers probably will stay to answer the questions. And our next presentation is titled Screening for Peripheral Arterial Disease in Diabetes Using the Ankle Brachial Index. It's going to be presented by Dr. Jerusha Owusu-Barnie from SUNY Upstate.
Hello, everyone. I appreciate the title of a doctor, but I'm not a doctor. So beginning of October 2024, we started to screen for peripheral artery disease using the ankle brachial index. So my name is Jerusha Owusu-Barnie. I'm presenting for SUNY Upstate University Hospital. And this is the map of New York State. We are located in Syracuse, New York, specifically in Onondaga County, where you see the red star. And so beginning of October 2024 to June of 2025, we began to screen for peripheral artery disease using the ankle brachial index for patients over 50 years of age that came in to see a podiatrist at our Joslin Diabetes Center. And so you can see that most of our patient population is located in Onondaga County, where we are located. And so for our ABI screening, we went by the guidelines for the Society for Vascular Surgery and the American Podiatric Medical Association. And as we all know, there are risk factors associated with PAD that includes cardiovascular, metabolic, and demographics. As one develops PAD, there are complications associated with it, and that includes cardiovascular events, foot ulcers, and amputation. So we initiated a PDSA cycle. Our aim was to screen 50% of patients over 50 years of age in 6 to 12 months. And this project began on October 18th of 2024. For DO, we started to screen Dr. Landy, who's our podiatrist, the patients over 50 years of age. And for study up to November of 15th, 2024, we screened 61 patients out of 165 patients that we saw. Of those, 17 were referred to vascular, 10 declined to do the ABI testing, and 1 was already seeing a vascular doctor. For ACT, we created a smart phrase in our EPIC EMR, and we also tried to provide resources and training to staff to increase the ABI testing screening accuracy. So here's our fishbone diagram. For policies and procedures, we kind of didn't have a standardized process for the workflow. There was also inefficient documentation of scanned images into our EPIC EMR. For patients, we had a lot of patients that fell under the exclusion criteria, and so we are not able to screen as many patients as we wanted to. And we have also had the issue of equipment limitation, whereby we had limited vascular cuff sizes, and so that also limited us in screening more patients as we wanted to. For process, we kind of didn't have a standardized process for referral to vascular. So a year prior to acquiring the ABI machine, podiatrists was screening fewer patients than we could have. So after acquiring the ABI machine, we were able to screen 88 patients. So that was around about 400% increase in our referral to vascular. And we also had the issue of time constraints. Established patients had 20 minutes per the appointments, and newer patients were limited to 40 minutes per appointment. For provider and staff, they had an issue of just adjusting to this new workflow, and that was causing delays, and also just being able to troubleshoot the device. So here's a flow sheet in our EPIC EMR. We have a spot to select yes or no, whether the patient screened for the ABI or not. You can put in the date, you can put in whether the patient was referred to vascular, and then we also have a spot for the exclusion criteria. So when you look at the right-hand side, you can see the various options that you can pick from. You also have the option to add in a comment if you so wish. And then down to the bottom, you have a spot to enter in the ABI results. So here's a table that has those that were screened for ABI and those that did not screen for ABI. So overall, we were able to screen for 245 patients. Mostly the mean age was around 67 years of age. Most of them were non-Hispanic whites with type 2. Most of them had type 2 diabetes with notable obesity and smoking history. And this data also has information on those that were referred to vascular and then those that completed their vascular appointment. So overall, we were able to refer 88 patients. The mean age in years was 67, mostly males. 60% were non-Hispanic whites. 80% had type 2 diabetes. And the mean diabetes duration was 26 years. And then this table has information on those that screened for ABI and those that did not screen those that had PAD present. and those that do not have PAD present after their vascular appointment. And so 18 of them were confirmed to have PAD, and older age was more associated with those that had PAD. Also, those that had PAD were had higher A1C. The A1C value was 7.9% versus 7.3% for those that do not have PAD. And then mean diabetes duration in those that had PAD was 31 years versus 21 years with those that do not have PAD present. And that was statistically significant. And also, we had smoking history being more common in those that had PAD. And look who it is, lying over there. So lessons learned, we had limited vascular cuff sizes. We also realized that education was more important, especially for the staff that were doing the ABI testing, and that was to increase our screening accuracy. We also learned that in implementing flow sheets in Epic and also a scheduling template in Epic really efficiently worked with our clinic workflow. So challenges include exclusion criteria, whereby we had lots of patients falling under the exclusion criteria. So some of them were patients having an amputation, the inadequate cuff sizes, some patients having pain or edema, unable to lay flat, plastic allergy, shunt or fistula present, wheelchair bound, and having a wound present. We also realized that there was a high referral rate to vascular surgery, and also that made us question how cost-effective this approach was. And also, people living with diabetes tend to have arterial stiffness or calcifications within their arteries. And so once they do the ABI testing, they tend to have inaccurate ABI results. So for our next steps, we want to continue to investigate this result inaccuracy and also further investigate healthcare disparities in implementing this ABI testing, particularly in communities with high comorbidities like diabetes. So I would like to thank the team for their help and support with this project, and also to T1D Exchange for creating this platform for everyone to share their work and also learn from others. And on that note, I'm happy to take any questions.
Thank you. Great and very important topic.
Thanks for that talk, Jordan Ross, Med Peds Endocrinology in Memphis. You've challenged me to do a better job screening for PAD in my adult patients. One thing I was thinking, sometimes I just defer all surveillance for a new patient, lots of insulin dosing, say at your 2-month follow-up. Well, I can start adding this to the list and be time effective. Because as you said, that's a big, to unexpectedly add that into a clinic visit when you weren't prepared for it is possible, but saying at the 3-month visit when we're doing your urine and talking about your eyes and your foot exam, that's a very natural thing to add. Was there, I get you called it a challenge. I think that is the reality is you will find disease and you will refer to vascular surgery. Have you talked with their department yet about their experience with this increase in referrals because you've appropriately screened and found the disease?
Yes, we actually have talked about it, and we just want to look going forward, just want to look further into how we have been having such a high referral rate and, you know, what the causes are, could be how the testing is being done or, you know, something else. So that is something that we are interested in looking at because the referral rate is, you know, kind of high. Yeah.
Other questions? Maybe I have a couple quick questions. So one is, as far as I know from the literature, that sensitivity of the ABI in diabetes patients specifically is very low. It's like 30-ish, 40-ish percentile. Specificity is very high. How do you address? So you probably for just generalized screening, so you might be still missing quite a few patients. I don't know if you had discussed that.
Sorry, can you explain the question more?
Yeah, so when we do the test, we'll look at this, how sensitive the test is for detection of the condition, and how specific it is with finding false negative and false positive. Yeah. So ABI in diabetes population, there were some publications that sensitivity is pretty low. The specificity is very high. It's like 90th, but the sensitivity and detection of disease or detection or ruling out basically the disease is pretty low. I don't know if you had discussed that to maybe add other modalities of the testing.
Yes, I think that has come up. We haven't discussed that into detail, but going forward, as we have a high referral rate, I think we also had some that had results that were like indeterminate. And we want to going forward, look into those patients that had indeterminate results and see, what the issue were in relation to, them having diabetes. And, going forward, we also want to figure out whether, there are other tests or something that we can do to help them in relation to the PAD.
Great, thanks. And another quick follow-up question, because I assume all those individuals were completely asymptomatic when you screened them. Did you encounter any issues with the insurance coverage for the test?
That I do not know. I don't know if the team has anything to add to it. I don't know if you guys have anything to add to the question.
Sorry. One of the things that we're looking at is getting better testing devices. So getting a better machine to do the better ABI testing. We have a basic machine, as you guys all can see in the picture, but we're working on getting some better funding resources to assist us with getting some better devices to help us with some of those results. So we're not referring almost every patient to vascular.
Great, thank you so much for excellent talk.
Hi, Nana Jones. I'm pediatric, so we don't do this at all. But there's been some increased surgeons of wanting to do foot screening in our pediatric patients, especially since we now have a growing type 2 diabetes population. And so I was actually intrigued by your flow sheet that you had. Did you create that as a result of this project, or was that already there? As some opportunities to potentially build this type of screening flow sheet for just general kind of foot exams for a pediatric.
Yeah, so we actually built it. We did the blueprint and then we sent that to our IMT team for them to build it for us. Yeah.
Okay, thank you for a great presentation and discussing this very important topic. And our next presentation is our quality improvement analysis of sick day rule, updates on DKA admissions in children with type 1 diabetes using hybrid closed loop insulin pumps. And it will be presented by Lindsey Shelby from Bonheur Children's Hospital. I'm sorry if I missed her.
Hi, everyone. My name is Shelby Lindsey. I'm a medical student from the University of Tennessee Health Science Center, and I'll be presenting research from Bonheur Children's Hospital on sick day rule updates that we did in order to try to reduce the number of DKAs we were seeing in children on hybrid closed-loop insulin pumps. So before I get started, I want to provide some background information about our population demographics. Bonheur Children's Hospital is located in Memphis, Tennessee. We have a catchment area of the 6 states shown here in red. The population of Shelby County, which is where Bonheur is located, is 28% above the poverty level, which is above both Tennessee and national averages. And when we look specifically at our pediatric endocrine population, 58% of our patients belong to a public payer class, and around 50% of our patients belong to a minority population. So for this research, we noticed that we had increased number of patients on hybrid closed-loop insulin pumps coming to the hospital in DKA. And so we first created this fishbone diagram to determine what is the root cause for this. And we identified a couple of different things. For policies and procedures, we acknowledge that sick day rules can be difficult to follow and complicated. Also, insurances have a lengthy prior approval process, and it can be difficult to get pump and CGM supplies. For the product itself, it can be difficult to acquire supplies. There's also sometimes connectivity issues between the pump and the CGM. We can have insertion site failures or problems with the pump itself. For the process, families are educated by the pump company, but may not fully grasp various troubleshooting techniques. We also always schedule 2-week post-pump start follow-ups, and these aren't always happening in a timely manner. And for people, it can be difficult to follow sick day rules, can be difficult to follow every step of the medical regimen, difficult troubleshooting, and then also having problems wearing the device consistently. And we noticed that around 25% of our DK admissions were due to insertion site problems. And so that's the area we chose to target for the first PDSA cycle. And to do this, we updated our sick day rules. The biggest change to our sick day rules is the line that says, and change pump site immediately under the moderate to large ketone part of the flow track. And we hope that by adding this line, it would encourage insertion site troubleshooting with our patients and timely site changes. And so we did chart review from January 2024 to July of 2025 and initiated our new sick day rules in February of 2025. So this shows our first PDSA cycle. So we first noted increased number of DKAs due to insertion site failures. So we updated our insulin pump sick day rules to emphasize earlier insertion site changes in the hopes that this would decrease the number of DKAs on insulin pumps. And then to do this, we rolled out new sick day rules in inpatient visits or inpatient admissions and office visits in February 2025 and onward, and encouraged physicians to document the cause of the DKA in the EMR. And here are our results so far. This graph is showing you the number of DKAs per month for patients on insulin pumps. And we can see after February of 2025, we don't really see a decrease in the number of DKAs that we're seeing per month. We think this is most likely due to an increased number of patients on the insulin pump. So this red line shows you the percent of our type 1 diabetics on insulin pumps from January 2024 to June of 2024. And you can see that number peaks at 43%. When we look at the same time period for 2025, we can see that number of patients on insulin pumps peaks at 49%. So we think that may be confounding some of our data. However, when we then look at the cause of the DKA, we can see that DKA due to insertion sites did decrease over that time period. So in 2024, around 27% of our DKAs were due to insertion site problems. And then in 2025, that decreased to 11%. The DKAs due to pump problems stayed approximately the same. DKAs due to infection decreased from 18 to 6%. And then we saw increased number of DKAs due to not wearing or pump upkeep failures. And this graph just reiterates some of the things that I just told you. DKAs due to insulin pumps remained roughly the same. Infection decreased, not wearing pump upkeep failures increased, and DKA due to insertion site failures decreased significantly. And so our revised sick day rules did effectively reduce insertion site related DKA. However, insulin pump related DKA of all causes increased after our revised sick day rules. We think that is likely due to an increased number of patients on insulin pumps. We know that insulin pump related DKA still persists, and we have several opportunities for further PDSA cycles to try to impact that, including areas such as lack of supplies and pump malfunctions. And so we're wanting further quality improvement projects to target those areas. So this is bringing back up that first PDSA cycle I showed you. When we look at the study, while overall DKA admission rates did not decrease, DKA due to insertion site failures or pump malfunctions did decrease. We want to continue to educate our patients on the new sick day rules, increase the accessibility of those sick day rules, and address other causes of DKA, such as not wearing the pump or supply issues. So I wanted to pull back the initial fishbone diagram to talk about some future directions that we're considering to target the difficulty following the sick day rules or maybe not knowing what your sick day rules are. We want to increase the accessibility of them. We're considering attaching them to a QR code that we can give patients to put in their wallet or magnet to their fridge so it's easier to refer to their sick day rules. To address the problem of patients not wearing their pumps due to supply issues, we're considering delaying pump starts until patients have time to acquire at least 2 months of pump supplies. So they have a reserve to fall back on when shipments are delayed or whatnot. And then for the process itself, we want to continue to improve our insulin pump backup plan and pump education and make sure our post-pump starts are happening in a timely manner. All right. Are there any questions?
Thank you. Any questions?
Hi, thank you for this. I think DKA sick days, especially with the increase in diabetes technology, is always a concern from the providers and diabetes staff. I wanted you to clarify 2 questions. One, to clarify, you said that you think that the rates of DKA were going up in your institution because of the increase in pumps, or was it the other way, like the graph that you showed? I'm sorry, just wanted.
So this particular graph is showing the number of patients on insulin pumps that are going into DKA. So you can see that it peaked at some point in 2024, like July, August range. And so we felt like we had more patients going into DKA on these pumps than should be.
Did you look at those on basal bolus to see if that there was a?
So you're talking about like on multiple daily
Yes.
injections. So that number is the number of patients in DKA on MDI is much higher than the number of patients on DKA on insulin pumps. And the overall number of DKA increased in both populations.
That's good clarification. I appreciate that. I also maybe want to push back a little bit on delaying starting insulin pumps to get 2 months of supplies. Hypothetically, that seems like the reverse of what we're trying to do. We're trying to increase, insulin pumps and automated delivery systems to our patient. I think maybe a more feasible alternative is to order a 90-day supply at the pump start. So I would push back a little bit on any types of delays in automated insulin delivery systems for patients with diabetes.
Yeah, I agree. I think that's a very fair comment. I think for some of our insurances, they only allow 30-day pump supplies. And so that also becomes a barrier. But I think I agree. We definitely want patients on pumps as soon as possible.
Great, thank you. Yeah, no, I agree with this comment about the delay because those delays would be anytime during the course during, so it's constant delay. I think we discussed this insurance issues yesterday. And
It was more, I wasn't part of this project. The other thing was, because we have we do the pump start orders, it gets approved, they set up the training. And so if there's like a week, even like go ahead and call for that first prescription before you've started it, because even a week will give you 2 insertion sites or 2 pods extra. So we're not telling them they need to wait 2 months to start it. We're saying the moment you can get a prescription, even add like the training and talk to us about starting it, like go to get the prescription right then so that you have even one. I mean, we create this like hoarder mindset, and it's like I have so many friends in our department with type 1 who like run out of stuff, and these families who have even less support potentially in their internal social support, like have one set extra by just calling 3 days before you're going to start it so that you have the one. So we're not telling them they need to wait 2 months to start it. We're saying we don't want you to start it and not have 1 month in the insertion site and then you've fallen off just after 1 month. So that was more that Shelby was saying.
And we haven't done any of these things yet. These are just brainstorming future PDSA cycles we're considering as we want to continue to decrease the number of patients on insulin pumps coming into DK. And supply issues was a big factor we were still seeing.
Maybe it's better other places, but you know, this was struck.
Yeah, it's not, thank you.
First month supply that you have the problem.
Well, every month, but if they get, yeah, if that week lag means they waited to call for the first shipment until they've had the training and we're ready to start it, that may be 1 week that they could have had 2 extras.
Yeah, we also always encourage, but those are adults, for our patients to call the company because they will always mail a few sets or just as a courtesy. And while I'm walking, the quick question, did you look by the age distribution, younger kids versus like teens?
I did collect that data as I was going through chart review, but we haven't analyzed that specifically yet.
Hi, Casey Rest, Children's Healthcare of Atlanta. Just kind of to keep on this trend, I guess. I think what we have kind of been trying to push is more so like, and with this same idea, not necessarily like a delay, more so educating patients on trying to make sure that they are right on time and like trying to get their prescriptions as soon as possible so that they have a little bit of a buffer. Because I think a lot of our patients are waiting until they run out before actually filling.
Hi, my name is Taylor Lee. I'm a nurse educator from Penn Medicine. Usually what we do in our practice is write for more quantity maybe than what's needed. So we write usually every pump order. I'm putting in so they're getting 10 extra sites every like 90 days.
Keep 48-hour changes with that too, and then open that offer.
Thank you all for the great comments. So we have more questions.
Hey, I'm Stan Haley from Cincinnati Children's. I was just going to comment on your accessibility of your sick day rules. That was my main question. Then you addressed that it was brought up in office visits as well as inpatient admissions. I'm assuming by your diabetes educators. But just would encourage obviously continuation of like diabetes technology review by all providers. And then we have created like a QR code accessible sheet so that people have it, they can save it on their phone. And we also agree like they're more likely to Google it than they're to like save their ABS. So we'll just encourage you to pursue that or something easy that they can remember, whether it's their QR code or it's like, oh, I go to this website and it's like sickdays.com or something like that.
Hey, it's interesting because we thought about the Googling of it. So I sat down and Googled, and it had our oldest version of sick day rules still on Google. It had the more recent one, and then it also had the brand new one we created, which would be so confusing for patients. So we went through the process of removing the older two. So now that Googling is definitely an option. We also handed out, we do a school care plan at their visits included. We also do an insulin pump backup plan. So anytime they have a change, they get the new insulin pump backup plan, which lives in their chart. And then we include sick day rules and the nurses explain sick day rules to families and then CDs inpatient. So
This would be our last question. Thank you.
I guess this question is more towards the group. And sorry, this is Alicia from Grady Hospital, CDCES. I really like the idea of putting in a prescription for a pump and telling the patient to get it right away. One of the challenges we're facing is that our patients are starting their pumps on their own. And I was wondering, because I like this idea of having the backup supplies, I was wondering what you guys have in place to prevent that, so that we can start the pumps appropriately.
We had that exact problem when Omnipod 5 came out. Some pretty scary situations from people starting and setting it themselves. So what we started doing for all people starting pumps, especially because AID systems are really different than just a regular insulin pump and CGM, is once the patient is scheduled for pump training, we actually do a pre-pump visit. It means that we spend a little bit more time, but we actually go through all the different nuances
of a hybrid closed loop, like treating lows with fewer carbs. And we also go through pump malfunction because that's the reason that people stop or go to CK a week later. So we do a lot of education before. It's about a 25-minute visit with a nurse, but we do it virtually. And that has helped us prevent all of that. It means like it's, no, it's prescription is made, the patient gets the pump, they're scheduled to meet with their pump trainer, but we do it like really within 3 days of that meeting with the pump trainer.
So we do that too, but we're having a lot of people who are still something. So we do the prescription and then either same day or schedule for training. Okay, so.
And then prior to the, yeah.
So we know so we started creating, we created a process now, so
Okay.
we know the steps.
Yes.
Of what the pump start should look like.
Yeah.
Okay.
That's it.
We created a process map, so patients have can navigate the system and know what the steps are, what has to happen before each next step. Otherwise, they get lost. Totally.
Thank you.
Thank you for all the great comments, and their wonderful session. I'm always, when I'm listening to all the pediatric resources and educators, they're always getting all jealous, like, how do we get this for dogs? And what kind of process map can we create? Yeah. Thank you.
Thank you.